Central nervous system, so acquired injuries, so concussion. We'll have a couple of talks on concussion. Just go quickly here. You can use essentially a SCAT5 to identify a number of the conditions, but generally speaking, any kind of direct blow to the head, generally speaking, rotational forces are worse. The other one is essentially where the athlete is not aware of the force coming. It is usually a greater predisposing factor to them developing a concussion. Generally speaking, of the athletes describing any kind of symptoms after a hit to the head or a quick acceleration deceleration injury involving the head, you want to consider whether or not they've had you want to ask them about concussion symptoms, so asking if they're having headaches, dizziness, lightheadedness, photosensitivity, and you want to take a look and see what their balance is, short-term memory, whether or not they're oriented, and also taking a look at the neck as well, making sure that they don't have an associated C-spine injury. In terms of from watching athletes with these, you want to also take a look to see if their performance is rapidly decreasing after an injury that happens during the play. That's going to be your indication to indicate that that's going to be an indication to have the player removed from play, so that they can be assessed. In terms of management, there's both short, immediate, and medium and long-term sequelae from a concussion perspective. So there is quite a significant amount of evidence to show that these athletes need to be removed from play. So if in doubt, make sure you remove them. It's going to be better for them in the long term. And then once they've, in terms of getting back, there's a number of return to play protocols we'll cover in a different topic. Subarachnoid hemorrhage. So in terms of significant head injuries, this is a bleed of the arachnoid membrane, a bleed between the arachnoid membrane, and the pia mater. Generally, you see this around the circle of Willis. 50% mortality within 30 days. Not common in sport, but it can occur in sport. And so, this is where somebody's describing a very, very, very bad, or sometimes referred to as a thunderclap headache, worst headache of their life. It's a rapid onset, and sometimes they'll describe it feeling like being shot. And there's usually some central nervous system symptoms, so take a look at the cranial nerves. Somebody's complaining of severe headache. When you're covering an event. From an injury perspective, this most often happens as a result of a blow to the head causing a cranial vault injury. You're obviously unlikely to know this with opposing players, but if you're one of your players, you're known to have essentially a history of aneurysms or family history of subarachnoid hemorrhage, polycystic kidney disease, or underlying connective tissue disorder, that's going to increase your risk of injury involving the subarachnoid area. Differential diagnosis, obviously, in migraine headache can be quite significant. Meningitis, stroke, and epidural hemorrhage, and subdural hemorrhage can all cause headaches. Generally speaking, in these players where there's, especially if there's not necessarily an injury, if they're complaining of a severe headache, you want to refer them to an emergency department for assessment and a potential CT scan. Epidural hemorrhage. So this is a bleed between the dural and the cranial vault. It tends to give a convex appearance on the CT scan. These are the ones where essentially athletes can essentially appear fine initially and then essentially have a sudden loss of consciousness or altered loss of consciousness shortly thereafter. Typically these are caused from a bleed of the middle meningeal artery following a fracture of the temporal bone in about 70% of cases. Differentials in subdural and subarachnoid hemorrhages. On examination, so they may, from an altered level of consciousness perspective, they may have some vomiting, headaches, feel drowsy or be confused, changes in speech, seizures. They may in fact have some stroke-like symptoms such as hemiparesis. Pupils may be dilated, and they may in fact have a Cushing's reflex. in terms of management, these patients need an urgent, emergent neurosurgical consult. So once again, these patients need to be transferred to the emergency department for assessment. That combination of kind of significant injury and significant symptoms with a cranial nerve examination as well. The subdural hemorrhage, so this is a bleed between the dura and the arachnoid matter. This is essentially mostly venous. So unlike an epidural hematoma, subdurals tend to cross suture lines and have a more concave appearance. So you can see the subdural on the CT scan on your right side of the screen. It's an axial load, and on the patient's left side, you can see, I've compared it to a banana, but you can see the concavity, and it crosses several suture lines. It's picked up obviously on a CT scan. The patient may have headaches, altered mental status, focal neural deficit seizures, and these patients for larger ones, need surgical decompression. It's not too uncommon in contact sports. In fact, some of these are picked up late because the smaller ones can be quite stable, but obviously larger ones are going to need the surgical decompression. The other one is essentially masters athletes. So it's another population in terms of consideration. They're on any kind of anticoagulation, you want to consider CT scan even for lesser mechanism injuries involving the head. Vertebral artery dissection, this is quite rare, but essentially you get a compromised vertebral artery. So either from a pre-existing aneurysm or from essentially a injury of acceleration, deceleration to the cervical spine. So if there's kind of a new onset of either very, very sharp neck pain after a certain maneuver, or essentially signs of global hypoperfusion, such as like dizziness, headaches, feeling lightheaded, profound nausea, vomiting, that are not in keeping with the athlete's baseline, this is something that you may want to consider. The other ones, in terms of essentially a manual neck manipulation, which might occur in some combat sports and wrestling. And the other one is essentially a trauma, such as essentially more of like a whiplash maneuver. These are very tricky, to be perfectly honest, to pick up, even from an emergency perspective. They don't typically show up on a CT scan, like a plain CT of the head. You need to suspect these injuries and then subsequently order a CT angiogram or MRI angiogram. Patients may not, in fact, even have any neck pain, so it just makes it further difficult to pick up. But from a sports physician perspective, you want to suspect this with any kind of neurological symptoms with a sudden head-neck movement. Intracranial hypertension, so these are symptoms of raised intracranial pressure without any kind of pathology. Typically is normal cerebrospinal fluid composition. And where you're going to see this is an athlete complaining of headaches when they exert themselves. Generally, essentially secondary to an intracranial bleed, a tumor or abscess. From an acute perspective, you have chronic ones, which may be either idiopathic or secondary to a head injury or some drug therapies. And they can be, once again, exacerbated by exerting oneself. The differential diagnosis, so you can have essentially post-traumatic headaches that persist after a concussion, subdural hematomas, epidural hemorrhage, subdural hemorrhage, and vertebral artery dissection. Don't be confused or don't be distracted by the fact that some of these headaches may in fact feel better with certain headache prophylaxis medications. That doesn't rule out the fact that the underlying cause may be intracranial hypertension. Examination. So from an examination perspective, the one you want to take a look at is from a fundoscopy perspective to make sure there's no papilledema, which is typically present in these patients. And it's kind of a diagnosis of exclusion, so you want to consider neuroimaging for anybody that has prolonged headaches and or headaches that are getting worse. So depending on if this is kind of chronic or acute, and in terms of acute, generally speaking, these people need some resuscitation and would need a neurosurgical consult or a neurology consult at the very least. With chronic ones, you may consider certain medications like mannitol to reduce. We would essentially want to have those patients referred to neurology for further management. Meningitis, so this is always concerned with traveling with teams, so you can have bacterial, viral, or fungal infections. Meningococcal disease essentially is spread from direct contact from the oral pharynx and nasopharynx of affected individuals. The differential diagnosis and encephalitis, subdural or epidural hemorrhages, and strokes can be mimics of meningitis. Patients will typically describe headaches, photophobia. They may have some phonophobia, neck stiffness, and obviously, if you see any kind of evidence of a petechial rash, it's very concerning for meningitis. And the other ones they talk about are Brzezinski or Kernick sign. There's also one where it's a bed shake sign, where you essentially go up next to the player and either shake the bench that they're sitting on or bed that they're lying on to see if that kind of aggravates their symptoms. Generally speaking, these patients are going to need to be referred to the emergency department where they can have investigations done, blood work, and a lumbar puncture to assess the cerebrospinal fluid. From a team physician perspective, the consideration here is that you want to consider giving prophylactic antibiotics to teammates, especially the ones that were living in the same space as that athlete. You want to try and avoid fluoroquinolones with respect to toxicity of tendons, so using alternatives when you're considering prophylaxis for athletes would be important. There are some congenital conditions such as Chiari malformation. That's where the cerebellar tonsils essentially kind of protrude through the foramen magnum. Interesting enough, sometimes it's not picked up on CT scan and may require an MRI. Often these are picked up incidentally, so somebody's had it for years. Generally speaking, they're asymptomatic and you don't need to do anything about these. There's always the question about risk with contact sports. Typically that's kind of reserved for athletes that are having symptoms or prolonged recoveries secondary to concussions. In those situations, it may change your mind. There's very little evidence, if any at all, of any kind of actual increased risk to players. Now, that being said, you can have an associated syrinx. So, with a syrinx, which essentially is syringomyelia, you have a cyst or cavity within the spinal cord. These can increase in size over time. These can be congenital or acquired. And generally, from a congenital perspective, that are secondary to the Chiari malformation. If it involves the brainstem, then they refer to it as syringobulbia. On examination, these patients may experience no peripheral symptoms, or they, in fact, may notice a progression of abnormal loss of pain, temperature sensation in the extremities and chest, weakness of the limbs, and potentially even temporary paralysis. Interestingly, the posterior vasovibration, touch, and proprioception is usually preserved. These patients need an MRI of their C-spine to diagnose this, and this is a contraindication to higher impact exercise, contact sports, weightlifting, or training. These patients need to see a neurosurgeon, and generally speaking, this can be treated surgically for decompression. So a couple of miscellaneous orders, common wrestling, herpes gladiatorum. This is essentially herpes simplex virus, where you see a cluster of vesicles, usually in around face or neck, direct contact to mats and sports, so we call it mat pox. Or for forwards, they can get essentially in rugby where they have direct contact in the scrum. They can also get this differentialism, molluscum contagiosum, shingles, kind of a fairly unique appearance. You can see on the image there on the right, like almost like tiny little pimples essentially. And some of them will coalesce, meaning they'll join to form an abnormally shaped vesicle or a larger vesicle. Best treatment is prevention. These patients may need, especially in certain competitions, may need to be removed from or may be disqualified from competing as a result. So you need to check with essentially the guidelines of the event and competition to see whether the player can play. And then they need to be on antiretrovirals, so either acyclovir or valcyclovir for a period of time. Acyclovir treatment generally 5 times a day. Valcyclovir essentially 3 times a day. And it is contagious. So you don't really want them to participate in one-on-one training from a wrestling perspective. Some other training in terms of you may have it wrapped up, but essentially you don't want them having any contact with any of the other athletes. Scalp hematomas, so direct trauma to the head, causing essentially 2 different types. So the deeper one is the cephalohematoma, or goose egg. Those are usually fairly localized. And then the second one is the subgaleal hematomas. That is essentially a little bit more superficial and can cover a large area. Obviously, you want to make sure there's no concern for any kind of intracranial injury. You can gauge that by considering how significant the trauma was and whether or not they're having any other symptoms or associated concussion symptoms. Whether you want to explore having them go to the emergency department for a CT scan. Generally speaking, if they're otherwise asymptomatic and they just have essentially goose egg, there's no family history of any kind of connective tissue disorder, aneurysms, bleeding disorders, and they're not on any anticoagulants. Generally, you can treat them with just using direct ice. And these usually resorb within a few weeks, and no special management required. Very large ones, you may need to do an IND or aspiration for them. Facial lacerations. So a couple of considerations. We talked about auricular lacerations already, but the other ones are essentially around the eyes and lips, which we already talked about. So from an eye perspective, for best cosmetic appearance, sometimes you may need to just essentially stabilize the player for transfer to the hospital for procedural sedation and proper cosmesis with having a plastic surgeon see that's more complex, or involves the eyelid, for example. You want to make sure that you're not missing any kind of associated facial fractures. Once again, checking the eyes for visual acuity and checking the pupils. Make sure you're not missing any kind of other associated injury there. Obviously, some things you don't want to ever do, putting staples in the face, or using anything larger than essentially a 5-0 size suture. So avoid any kind of 1-0 to 4-0 size suture. And then have a low threshold in terms of referring to plastics. They can often give a very, very or much superior cosmetic result, especially if you're not used to doing a lot of laceration closures. Tom also recommends, if you're doing lip lacerations, to use magnification, which is actually very good advice, so you can always visualize that vermilion line. So in summary, conclusion, talking about head and facial injuries, these are usually involve more significant trauma, and you also want to consider your ATLS protocol, so your advanced trauma life support. So keep in mind your ABCs and your cervical spine. So you want to stabilize that cervical spine until you've essentially cleared it with the patient. And also considering any kind of intracranial injury. So have a low threshold for referring patients to the emergency department. for further investigations with CT or potentially MRI or CT angiogram, depending on what you believe is going on or what the emerge physicians believe is going on. And from that perspective, the vast majority of head and facial trauma in sport will require further imaging. And that when we're talking about head and facial trauma, we're talking about more significant head and facial trauma. So where there's essentially not an overt, essentially, facial laceration, facial swelling, deformity. Those are the ones, as opposed to, just a knock to the head, where they may have some concussion symptoms. So make sure you refer those patients that have essentially obvious injuries earlier, as opposed to later. Tom also recommends that you befriend a specialist in either plastics, ophthalmology, and maxillofacial surgery. His recommendation is consider bribing them, but I think it's good advice from a networking perspective. It's helpful to have somebody that can give you advice on some of these rare injuries when they do occur. Make sure when you're prescribing that you check out Global Dro to see if the medication is appropriate or not, whether or not it may in fact need a therapeutic use exemption. And there's no excuse for a team or athlete getting banned as a result of not checking that very good website, Global Dro, GALOBAL, Dro, DRO. He also recommends, obviously, from an indemnity perspective, that's also important to make sure that you're covered. And that's the end. Once again, we want to thank Tom O'Neill for putting together this excellent review of head and facial injuries. Thank you very much.